Hello, this is Brian Byrd, Assistant Professor in the Division of Cardiovascular Medicine at the University of Michigan. I was invited to write a narrative review of strategies to personalize the treatment of hypertension. In this video, I'll highlight and amplify some of the ideas I expressed in the paper. According to the World Health Organization, hypertension is the leading risk factor for the global burden of disease. Per several recent guidelines, there are 4 drug classes recommended for initial treatment of high blood pressure. There are just a few situations in which these guidelines recommend that the drug be matched to the patient in question. However, the efficacy of blood pressure lowering attributable to a given drug is not the same in all patients. Beyond the issue of efficacy, the safety of the drugs varies from patient to patient. Some patients develop life-threatening angioedema when exposed to ACE inhibitors, for example. Patients much more commonly experience adverse effects that are not life-threatening, but that nonetheless diminish their enthusiasm for taking antihypertensive medications. These adverse effects are a key problem in the treatment of hypertension, since, as C. Everett Koop pointed out, drugs don't work in patients that don't take them. Currently, providers and patients hope that the selected drug will be effective and well tolerated, but it's widely recognized that hoping for the best is not an ideal component of a therapeutic plan. Thus, many efforts are underway to match the treatment to the patient. As we ponder personalized therapy, I would challenge researchers and clinicians interested in hypertension to consider where have we been, what are we doing today, and where are we headed in the future. Based upon the work of Lara and colleagues as well as others, renin profiling emerged as the leading pragmatic approach to tailored treatment of hypertension. In general, as plasma volume increases, plasma renin activity decreases and vice versa. This relationship has been used to select treatment, but there are some limitations to the approach as discussed in the paper. Another strategy that has been extensively evaluated is assessment of genetic variation to predict response to antihypertensive medications. Estimates of the heritable contribution to hypertension vary from 25 to 65%, depending on the methods used. Environmental factors then contribute substantially to hypertension, so we shouldn't be surprised if we're unable to predict response to treatment by examining the static warehouse of DNA present in our cells since birth, except in the instance of certain very rare mutations with large effect size. To personalize the treatment of hypertension, we'll likely need to use new means of assessing patients' physiology. Thankfully, we have scientific tools available to help us discover novel aspects of physiology. One promising way forward is to carefully assess the molecular physiology of patients with hypertension. For example, RNA transcripts and epigenetic modifications should attract our interest since these targets integrate information about genomic and environmental influences on blood pressure. Thanks for your attention, and I hope you enjoy reading the review article.